So good afternoon, everyone. So I would like to introduce Dr. Vedang Vaidya. He is a bachelor's and a master alumni from our institute. His bachelor's was done at, I think, which college was the bachelor's? Okay. So he's a bachelor and master's alumni of Sancheti. He's done his elective in sports and he's a registered OTPT member and also a clinical consultant at C4 Diagnostics in Juhu, Mumbai. He's also been associated with the Mumbai School Sports Association for the Harris Shield and the Gills Shield. His previous affiliations are with Mumbai Cricket Association as well as with Maharashtra Cricket Association and Gujarat Panthers for the Tennis Premier League. So I would like to invite Vedang sir to now kind of take a title which is little different. He wanted to come as an alumni only. He didn't want us to give any other introductions. But I thought at least this brief introduction is something which was a mandate. He wants to talk to you about what he learned beyond the classrooms. So as a sports physio, as a person who had been trained here, how did his rehab perspective change beyond once he started practicing? So over to you, Dr. Vedang.
Hello, everyone. I would like to start by thanking Sancheti College of Physiotherapy and its Alumni Association for inviting me to have this talk. To begin with, how much of a difference there is to what we learn in the classroom and our clinical postings to a real-life clinical scenario? Not much, actually. What we learn in the college is like a base on which we further build our practice. Now, talking specific to sport, why is there a difference between traditional rehabilitation and sports rehabilitation? So most of these athletes who have been training their whole life, they have good muscle strength. So unlike our traditional rehabilitation cases, they don't have a lack of muscle strength, but they might actually have a reduced activation of certain muscles while performing certain activities. Now, few things. Firstly, let's talk about the pain tolerance. The pain tolerance level in athletes is very high. What sometime we might think or mistake is that we tend to correlate absence of pain post-injury to a successful completion of the rehabilitation. These players have had n number of injuries in the past and have a high intensity training sessions usually. So they really push their pain past their tolerance limit every time to new boundaries. Next is the psychological influence, which plays an important factor in terms of rehabilitation, as well as the game. Constantly thinking about a niggle or post injury, thinking about staying away from the team or losing their spot in the team burdens our athletes. This may lead to them either providing an over input in their game or an under input during their game or the practice, both of which can harm. Next is the time bound recovery. There is always some pressure from the management, from the player himself, as well as from an upcoming tournament that we need to get back on field. We need to play this tournament. Lastly, the extent of rehabilitation. Especially when you're associated with some team or are traveling with a team, you tend to have the athlete in your care for a longer time. So your rehabilitation should grow with every level. Now let us imagine these two players having a lovely day of cricket, but unfortunately because of us, they're going to get injured. So our bowler, let's say in follow through of his delivery, plants his foot wrong and twists his knee while falling. On the other hand, the batsman is complaining of posterior thigh pain most times while running. Two completely different scenarios. One high intensity sudden onset injury, while the other is a slow evolving type of injury. So what will our role be in this scenario? Yes, for the bowler, a good swollen knee inability to bear weight will require him to get off the field. But of the batsman, should we take him out of the field so quickly? A quick evaluation can show us issues with the hamstring, but the player is demonstrating good strength when we are doing an isometric resisted strength evaluation and is willing to continue his play. Should we allow the same? Most of it depends on the game as well. At what stage our game is, can the team still perform without him? completing his inning, or even if you want to take him out for some time and then reintroduce him in the game post your treatment, but in a completely different scenario and as a different role in the team. So the decision making is based on your evaluation, the game scenario, the team management, and the player himself if he really wants to get off the field or he wants to continue to play. Let's talk about why the injuries actually happen and are they avoidable. Let's take an example of a player with a stiff ankle, generally complaining to you about the same, and a small niggle in the back of the ankle. You ask and find out that yesterday he or she went for a run for a good 10 kilometers first time. The food in the mess was not a favorite one, so dinner was also not done properly. Got late to sleep because he or she was studying for an upcoming exam, and early morning again a new practice session was scheduled. So an athlete who has an internal risk factor of a stiff ankle got various external risk factors like new or an excessive training, lack of sleep and recovery, improper nutrition or hydration, and stress, which all made him from a predisposed athlete to an injury to a susceptible athlete. So while evaluation, all these things should be checked in. All he needs is a one small inciting event to land up with a major injury. Not only specific injured joints, but also internal risk factors in the entire kinetic chain should be assessed. And in case of athlete, always before start of any new season, a screening should be performed to provide him with a prehab to have some change in modifiable risk factors and team meetings plus inspections to avoid certain external risk factors as well. In your assessment, you should know what is normal for that specific athlete or for that specific game which he is about to take part in. Let's take an example of a pitcher who has increased external rotation range on his throwing arm and reduced internal rotation range in the same. Let's say about 20 degrees gain in external rotation and about 15 to 20 degrees of loss for the internal rotation. Is it normal for him? Yes, that is his natural adaptation for the game. Plus the total arc of internal and external rotation is maintained. But let's say the proportion for the loss is far more than the gain. Then we can classify him as having an internal rotation deficit. So to start rehabilitation in this injured athlete, you want to establish an interdisciplinary approach. Pain management with help of sports physician or orthopedic doctor, contralateral strength training as part of a cross-training concept, and strengthening of the uninjured areas with the strength and conditioning coach. Obviously, first under supervision of a physiotherapist. Nutritional management, your player cannot have the same meal as that of the other players. He need good healing foods. Plus the rest of the players will be having carbs and fat loading to make up for the calories burned in the session. But since our injured athlete is not going to have the same intensity of his training sessions as that of others, there might be a significant weight gain in this athlete, especially when your athletes have specific weight criteria like that in a wrestler. And the most important thing is to have psychological support from your coaches and the selectors. Go finish your rehabilitation, get healed, come back. We'll again check what we can do. Okay. So now let's talk about the physiotherapy sessions. After assessment, you also need to check if they will actually be compliant to your specific protocol, especially in case of general population. If you overburden them with exercise of about a list of 10 to 15 ones, they might not do even a single one of it. But if you give according to your current goal, 4 to 5 of most important one exercises, then they might try and be regular with it. They might take their time out to do 4 exercises rather than taking a huge time out of their schedule to doing 15 to 20 exercises. Patient education, what we usually talk about, should not only be about the need of physiotherapy in their condition, and about their condition, but also about the exercises, where they should feel the exercise, the correct technique, the form of exercise, and breaking down your sessions into session goals. So these session goals can be working towards a functional goal for the patient. Let's take case of our ACL injured and operated bowler. His primary functional goal will be walking. So direct your session goals in such a way. You will require the necessary range of motion, quadriceps activation, which will only be strong enough when the inhibitory factors of pain and edema are reduced, and some other precautionary measures. So the exercises which we take for our athlete can remain same, but can be still altered enough to be broken down to according to our session goals. So quad activation, hamstring activation, ankle pumps, supported SLR can all be done in an elevated position, starting from distal to proximal, and repeat for the second set in the same way. So as to when my session goal is edema reduction. And with time, alter your session goals as well. Also with time, you are bound to get smarter. You can get your composure with time, as well as the vague generalized symptoms, they're reduced with time. Let's say in case of our batsman of complaining of hamstring injury, hamstring strain, the symptoms have reduced. He was already showing good strength, demonstrating fair strength during primary evaluation. Now 90-90 test is not giving any pain. So is he ready for play? Can we take him back to his play? What happens is he was complaining pain while taking a run. So when you take him in a range of motion more than 90 degrees and then check for his hamstring stretch of 90-90 and check for reproduction of symptoms, you might actually get some reproduction, because he was getting his pain when he was trying to open up his stride during sprints. So might be a case of a proximal hamstring tendinopathy. Again, participation assessment, a very important thing that what all players can do with the team. What sessions he can participate into. Can he do basic catch practice, standing at one spot, avoiding jumps and dives? Can he train for upper limb in the gym along with others? What all exercises for the upper limb won't give him trouble in his legs if he has a lower limb injury? Next, an important aspect is that after a week or so, do not work harder than your patient. Do not overwork yourself. We are physical therapists. We promote physical activity. We promote movement. It should not be the case that your patient is coming for a 30 minutes of session. You're working on him for 25 minutes. In the last 5 minutes, he does stretches on his own and goes. Every treatment session should be a new assessment of sorts. Do proper movement analysis when your client is doing the exercises. While doing an SLR, is he doing the straight leg raise in a clean way? Is the knee giving away minimally at the initiation while overcoming inertia? So it can tell you that the quadriceps activation is poor. If your patient is doing a knee to chest and feeling a pinch in front of the hip, you can tell that the hip flexors might be tight, which is giving the issue. In case of a low back pain patient, while going for a walk or while walking on a treadmill, he's showing some altered pattern. He's showing his leg rotated outwards after some time of walking. It can be because he's avoiding a pinch of the nerve in the piriformis muscle. It can be that his hip flexors have poor endurance, that's why he's substituting those muscles. Or the pain in the back is not because of any structure in the low back, but is actually due to hip pathology, and he's avoiding internal rotation altogether, which is painful in most of the hip cases. Then your exercise specificity. Exercise specificity is very important. The athlete is exercising or working out or playing most of the day. You want the exercises you give him to be very specific to avoid overtraining as well. You need to know what and when you want to target, and actually what do you want to target is being targeted or no by your exercises. Let's take an example of sumo squat. You can do an experiment yourself. Get up from your position, perform a sumo squat and hold it in the squat position. Check where are you feeling the maximum pressure. Sumo squats is something we usually perform to target the glutes more, but you may find it that you're hardly feeling it in the glutes and your quads are burning up instead. What you can cue yourself is to give a very minimum outward push with the knee to activate the glute and then maintain this activation while doing the sumo squat activity. Then the type of contraction you need, concentric for form correction or training of explosive movements, like to improve the vertical jump height in your patient, or eccentric to load more the proximal and distal portions of the muscle, or to reduce the metabolic workload on your patient. Then the range or arc of your exercise. Take an example of a bent over row, single arm bent over row. When your goal is posture correction, or if your patient has sprained his rhomboids or middle traps or so, you want a good static isometric contraction, then your cue of pinch, roll back and pinch your shoulders together full time, pull your elbows back in a row is probably correct. But when your session goal is strength training, then you need a full arc of your protraction to a retraction. The time under tension, how you want your tempo to be set off. It's all based on your session goal. Concentric training, eccentric training can be prioritized by changing the C is to I is to E ratio. That is your concentric, isometric, and eccentric ratio. Sometimes when your exercises are giving pain, even changing this ratio can make the pain go away rather than just completely avoiding that specific exercise. And then the energy transfer. Do you want your eccentric phase, elastic or potential energy to be transferred into the concentric phase, or you want to dissipate that energy, make the patient put in more effort during the concentric phase as well, especially during form training? Stretch specificity. Similarly, what do you want to achieve with the stretch is something which is important. You want to reduce overactivity of the muscle, then active stretching can help when the antagonistic muscle is working and your agonistic, that is the muscle which you're trying to target with the stretch, is relaxing. Or when there is presence of pain, you can use PNF stretch to give better results. Your range or arc of stretching, if your session goal is VMO activation, then you can alter the stretch of the quadriceps and hip flexors to a Thomas position so that you can avoid that end range of knee flexion stretch. And then if you want energy transfer, like a quick TA stretch will aid in improving the contraction of your gastrocnemius for a jump. Similarly, proprioception and balance should be specific to your session outcome and to be specific for the area targeted. If you're targeting the knee, you're doing basic balance training with a lock knee, then it's going to work mostly at the ankle joint. You need to keep the knee unlocked for it to actually target the knee. The specific muscle you want to fire, like if you want the trunk muscles to be active, if trunk stabilization is your expected outcome, then a displacement force to be provided above the desired level. If you want to target sport specific recovery strategies like air collisions and recovering from it while landing, like what happens in football when there is a corner kick or a free kick, two or more players are tackling in the air and then landing down. So you need to have some similar recreation of scenarios in your training as well. Late multidisciplinary approach. Let's first talk about including a good warm-up and cool-down program in our session. It mimics your player's everyday routine, plus it aids in your session. What was your previous session protocol can act as a warm-up in the upcoming sessions. That is your activation of correct muscles or range of motion activities before going on to more of a sport-specific training in your current session. Now, talking about sport specific training, it should be according to the desired muscle role and action as well as the position. So shoulder instability in overhead athlete should be trained for stability in an open chain position as well as closed chain, because that's how his shoulder is going to be while performing the sport. Fitness training to be started with sports specific activities with the strength and conditioning coach. You can incorporate mental imagery in your training as well, or you can recreate certain support scenarios during late stage training, like keeping a balanced disc and doing a few throwdowns to your batsman with an ankle injury to land on the balanced disc with his injured leg and to stabilize the leading leg while hitting the ball with the bat. Checking and training for psychological readiness by a sports psychologist, as well as role recognition by the coach. Can we get him back to play sooner in a different role? Can, by talking to my captain, I can hide the player in the field so the ball doesn't go to him so often, so he doesn't have to sprint much towards the ball. So this is how our rehabilitation needs to progress. Get required clinical clearance. That is your pain, swelling, range of motion. Then before returning to sports criteria, check for functional clearance. Can the athlete do a single leg squat before I make him do single leg hop for distance? Then after return to sport criteria is fulfilled, comes your psychological readiness. Is the player actually ready to return to sport based on his psyche? Then comes your return to participation in sports, which like take a case of a tennis player can be just a half court volleys first, then a doubles game, then singles game, uh, which are your friendly games, of course, and then followed by return to competition. And the most important thing is to train your athlete in the danger zone. They are bound to go in those zones during their play. You can only cue your athlete till the middle stage of rehab that don't let the knee rotate and fall in. In late stages, you need to take him in that position and train him to come out of those positions and have stability and control in those specific positions as well. Now, to summarize what we talked about, just adhere to your athlete for long. Make sure you use those late stage of rehabilitation strategies which you've learned in the classes which we have discussed about. Include the athlete's coach, your fitness trainer in your decision making. Every sport is a team sport. The entire team is going to come into picture when you're rehabilitating the athlete. Perform everything with a specific reason. Do not overburden your athletes with excess exercises than what he's already doing multiple times a day, and be specific with your plans. So thank you all for those who stayed till the end of the talk. I know it was some sort of repetition, some new things which we talked about. And thank you again for the opportunity. Hope to get such more opportunities to interact with everyone soon. Thank you.